All right, welcome back everyone to the Governor's Opioid Response Seminar Series. At this time, I would like to briefly introduce myself. My name is Josh Miller, and I'm the new Opioid Response Project Manager. I hope everyone enjoyed Governor Mills' third annual Opioid Response Summit in July. Excellent job to everyone who participated. Normally, this series occurs the first Friday of every month. However, due to the holiday weekend, we decided to host this event on the second Friday of the month. Please note, moving forward, we will plan to have this series on the first Friday of every month. The next series will be Friday, October 1st from 11:30 to 12:30. The topic for next month will focus on the Spike Text program. This program distributes emergency text alerts to the public when drug overdoses suddenly increase in an area. Also, the Maternal and Child Health and Substance Exposed Infant Conference is coming up on September 28th and the 29th. You can register on the AdCare website. We will now shift our focus on today's seminar, which features the Maine Naloxone Distribution Initiative. I ask that you please put any questions in the Q&A box instead of the chat. We will make sure all questions are answered and posted on the Governor's Summit webpage. An email containing the link for the evaluation of today's series will be sent on Monday. Certificates of attendance will be emailed next week. This seminar is being recorded and will be posted on the Governor's Opioid Response Summit webpage. I will now turn it over to Alex Rez, who will help facilitate this presentation.
Thanks, Josh. My name's Alex Resk. I am a researcher at the University of Maine who provides support to the Maine Naloxone Distribution Initiative. I'm going to start sharing my screen now for the presentation. Please let me know if anyone has issues viewing this. So today we will be discussing, as you know, the Maine Naloxone Distribution Initiative. You'll be hearing from myself representing the University of Maine, Denise Smith representing Bangor Public Health, Shane Gallagher representing Maine General, Bridget Rauscher representing Portland Public Health, and Hillary Esslinger representing Maine Access Points. We'll be discussing some key points today, including the background of the Maine Naloxone Distribution Initiative, running over distribution logistics, the construction of the MNDI, and what its function is, some information about Naloxone 101, addressing common questions about liability concerns and clinical and harm reduction-oriented FAQs around naloxone. The meat of the presentation will be the T1s in profile, discussing our Tier 1 naloxone distributors across the state of Maine, insights from their distribution areas, and specific snapshots about their T2 networks of sub-distributors that are facilitating this project throughout the state. We'll then discuss some challenges and successes of naloxone distribution in the state of Maine so far. And finally, we'll have some resources at the end of the presentation for finding more information about naloxone, including an upcoming, as of today, naloxone distribution website, getmainenaloxone.org, and the Extant ODME mobile app for overdose response and naloxone education throughout the state. So the origin point of the Maine Naloxone Distribution Initiative lies largely with Governor Mills' 2019 executive order directing action to combat the opioid epidemic, which specifically called to make naloxone more widely available throughout the state, affordable and accessible. As part of this effort, OBH and SAMS have mobilized funds to acquire both intranasal and intramuscular naloxone for distribution to both organizations and end users who were unable to acquire naloxone via other means. Over time, since the project's inception point in 2019, the MNDI has grown into a multilateral distribution and training network across the state, bolstered by several multimedia resource campaigns for public education and outreach and destigmatization around overdose response, including the hashtag Have It On Hand campaign, the Know Your Options campaign, as well as partnerships for digital media between the University of Maine and the Office of Behavioral Health, such as the ODME mobile app. What is the MNDI? Well, it's a distribution scheme that sees every county in Maine provided access to no-cost, low-barrier naloxone via the bifurcation of the state into 3 primary distribution zones that are geographically bound, as well as a network of peer-to-peer and organizational supply. Our 3 geographically bound distribution areas are assigned each a public health organization that we consider a Tier 1 distributor. These would be Bangor Public Health, whose purview is northern and down east Maine, Maine General, who services central, western, and mid-coast Maine, Portland Public Health, who services the greater Portland area and southern Maine, as well as Maine Access Points, who provides peer-to-peer distribution and organizational support across the state. Between these actors, every county in Maine is supplied MNDI naloxone. Each T1 is responsible for distributing naloxone to both requesting agencies or persons within their respective catchment areas per steering committee naloxone-wide policies as well as individual protocols. Once an agency in particular receives state-funded naloxone from a Tier 1, they become what we consider a Tier 2 distributor. In our program evaluation internally, we break these Tier 2 distributors into two rough groups, principally have-it-on-handers and redistributors. Have-it-on-handers are organizations we consider T2s who are requesting small batches for internal preventative bystander use. These are usually single-time requests, or they're expanded over time, but at a low frequency. Whereas redistributors are the primary vehicle of MNDI supplied naloxone throughout the state. These redistributors request naloxone usually in bulk with the intent to disseminate that supply to a community of clients or end users throughout their service areas within their localities. And their requests are usually part of ongoing harm reduction efforts. So they're usually return supply recipients. The pathway to becoming a Tier 2 naloxone recipient or redistributor is varied, but pretty straightforward. The principal resource thus far has been the naloxone request form, which could be found at the Office of Behavioral Health survey link that's provided here. And these slides, I think, have been provided to the audience as a handout, so you can find these links for posterity there, via the Maine Drug Data Hub, via the direct contact with the T1s, and their contact information will be provided in these slides. You can follow up with them after the fact. And as of today, also on getmainenaloxone.org, which we will cover in greater detail before the end of this presentation. Each T1 has fairly unique, but not too differentiated protocols and stipulations for their T2 onboarding process. Generally, three key areas the T2s who are going to redistribute need to comply with are that they should be covered by an active standing order. They should abide by any mutually agreed upon MOUs with their requisite T1s, and that they're also receiving the proper training for naloxone administration. A few key programmatic snapshots of the MNDI so far are that since its project inception point through March of this year, the MNDI has, through both its T1s and its T2 networks, distributed over 76,000 doses of naloxone and recorded nearly 1,700 voluntarily reported overdose reversals. In the first quarter of this year alone, our T1s and T2s distributed over 16,000 doses of naloxone and recorded nearly 383 voluntary reported overdose reversals. And that number has since that time gone up. Here you can see project start through July of this year, distribution visualized in the corresponding map. As you can see, there's a diverse range of localities that have received naloxone from this project at various rates of saturation. While that is diverse, you can also see that there's a clear pattern to the service areas and population zones centered around the highway corridors throughout the state. As of July this year, the project has dispensed over 100,884 doses of naloxone since project start. The MNDI is also serving as a collaborative nexus for a varied group of state actors operating in the harm reduction and overdose response space, principally partnerships between public health, public safety, and emergency responders. A keystone project in this regard is the recently unrolled Options program, which sees co-response liaisons operating alongside law enforcement to provide continuum of care support from victims of overdose. And the MNDI is supplying those liaisons with naloxone. Through the pipeline coming soon, there's also going to be EMS leave behind naloxone kits made available for non-transporting EMS that are responding to overdose events, either for the victims of overdose or for active bystanders, friends, and loved ones. We'd also like to take note of the fact that the Office of the Attorney General has been dispensing naloxone since 2016, and this project has existed alongside and in partnership with the MNDI, and their work is going to be ongoing as well through law enforcement and jail administration through 2022. Now we'd like to provide some key points on naloxone 101 questions that are common for trainers when educating people about naloxone. Primarily, we often get questions around liability for distribution sites and for individuals and for those who choose perhaps not to be active bystanders. For the purposes of this presentation, more details on these legal questions will be made available either in the Q&A section at a following date or on getmainenaloxone.org, where we will have an extensive section on the liability concerns with links to the requisite legislative documents to answer any questions you might have. But for a brief overview, we can discuss the fact that for organizations or distribution sites, while individuals are covered by the naloxone community rules, the distribution law, and the Good Samaritan law, sites are usually covered by principles of negligence, and that's fairly beyond the scope of today's presentations. There are protections for individuals, however, as I've said, both under the distribution law and the Good Samaritan law, which sees people made immune to criminal prosecution in certain instances when they're responding to crises, such as an overdose. And the Good Samaritan law does have specific provisions for people administering naloxone to someone suffering an overdose. Those who can carry naloxone are people who have received naloxone under the statute from an authorized source, such as a tier 1 or T2 provider under the community distribution law, or who have received it from a prescribing physician or pharmacist. At this point, I'd like to hand the floor over to the first of our tier 1 panelists, the executive director of Maine Access Points, Hillary Esslinger, who's going to address some harm reduction related questions about naloxone before moving into the tier 1 profile portion of the presentation. Thank you. Hillary, take it away.
Hi, well, thanks so much for having me today. So I just wanted to provide a little more kind of naloxone 101. So it's really important that individuals understand that if you give someone naloxone and they are not experiencing an opioid overdose, it's not going to cause any harm. There are no negative side effects. And that's kind of magical. You know, there aren't a lot of medications that give us that sort of freedom to train lay people to respond to each other. Similarly, someone cannot overdose on naloxone. And if you are responding to an overdose, you are not at risk of experiencing your own overdose. So that just tells us that it's really safe to respond to friends, family, strangers, that we are not at risk of hurting them or ourselves. Naloxone is safe to use on anyone, children, infants, elderly folks. We can use it. The dose is the same. It's consistent. There is no difference between the effectiveness of intramuscular naloxone and intranasal naloxone or Narcan. They both work really well. And for most people, it's just about what you're comfortable with and what our supply is. Sometimes people are concerned that someone will wake up from an overdose and, you know, be like really violent or aggressive. And that's really just not the case. Certainly individuals can respond to chaotic, fearful moments in a wide range of reactions, and that's really normal. But for the most part, when someone's waking up from an overdose, they are kind of drowsy, right? They're moving in and out of consciousness, and we just want to make sure that we are providing them with comfort and kind of welcoming them back from that really scary experience that they had. So now I'm going to move into a conversation about Maine Access Points, or MAP. And to kind of ground our organization, I have been asked to have a conversation about the history of overdose education and naloxone distribution. And it's a really beautiful history. Overdose education and naloxone distribution has its roots in the harm reduction movement. This work was started by people who use drugs, who were creating networks of care to save each other's lives. For a long time, the drug war made it so that that was not legal, but we are now lucky in many states in the United States and in Maine, we are able to distribute naloxone to each other, train lay folks under community distribution laws. I really like to share these words when talking about the history of harm reduction and really kind of grounding people in how MAP provides these services. These words are by our board member and teacher Eliza Wheeler. So she says, when we think of overdose prevention, of reviving people with naloxone, we do not think of it as a simple public health intervention. We think of it as an act of restoring life, of air, of breath, of allowing for the energy in a human being to begin moving again, to be reanimated. The concrete life-saving act of administering naloxone and restoring breath is also a symbolic act of friendship, of connection, and of a radical refusal to allow someone to die alone of a preventable death. The act of restoring life to a friend, a family member, a stranger, this has deep ripples outward, re-envisioning the way we treat each other, the ways in which we see each other, and value the lives of people who use drugs. And so MAP really was created with this deep reverence for the history of this work. Being taught by leaders in this movement, Dan Bigg from the Chicago Recovery Alliance, who started this work in the United States and abroad, we knew that networks of harm reduction existed in Maine. And we really wanted to just connect us together of folks who use drugs, of folks who love people who use drugs, to make sure that we could get naloxone to those who are at highest risk. So our mission is to recognize the resiliency of people who use drugs and to work in collaboration to create access points for overdose prevention and harm reduction services in Maine. And part of that is our overdose education and naloxone distribution program. We have a phone that folks can call, text, or signal to reach out to get naloxone through the mail, in-person drop-offs. But we also have this really incredible, powerful group of peer distributors across the state. Our distributor role, so our tier 2 role, looks different for each person, and that's exactly how we intend it to be. We're meeting people where they're at and really trying to explore what distribution looks like for them. Our distribution team is made up of individuals, organizations, recovery centers, organizers, syringe access programs, and they just give out so much naloxone across the state. Our distributors are given a 3-hour training with monthly follow-up and monthly check-ins. So we provide check-ins with each member of our team, at least monthly, but ongoing. And then we have some meetings that distributors can attend to. Our distributors are responsible for enrolling participants, training participants, maintaining inventory, getting us data back. And again, we're working with all of them to make sure that the role is within their capacity, that they are getting the support that we know that we all need in this work. So we also provide aftercare and support to individuals who experience their own overdoses or who respond to overdoses. That's a really quick snapshot of Maine access points. I do encourage you to reach out if you are interested in being a distributor with Maine access points. And now I'm going to turn it over to Denise, who is with Bangor Public Health. Thank you.
Thank you. So I'm Denise Smith. Thanks, Hillary. It's always so hard to go after Hillary. Why do I? I really appreciate all the information that, and I just want to take a minute to say, I really appreciate working with this group of people. We've learned so much here at Bangor Public Health. Me too. So I've been in this position at Bangor Public Health for the last year, and I started in July of 2020. And so what I'm really going to do is talk about the evolution of our program and talk about from where we were from July 2020 to July 2021 and highlight some of our successes and some of the challenges and really the demographics of our program. And that's what this slide does. It just highlights the 5-county area that we have. Again, most of our area is very rural. The rural areas have their own unique systems and needs and infrastructure. And we really work with those local organizations and agencies to supply Narcan to them so they can redistribute into their communities. We only distribute nasal Narcan. We don't do any intramuscular Narcan and work with them. They know their communities best. So this basically is moving into the demographics of our area. When we were in 2020, July 2020, we had 24 tier 2s, and this is the breakout of the distributors at that time, the county. The next slide is in July 2021, we basically had just about doubled the tier 2 distributors and moved into 47. As of today, we have about 50, and we have several more that are in various stages of the onboarding process. This is just another sort of breakout of the types of agencies that make up those 47 tier 2s and the different types of agencies that we have. The additional 3 that we have coming on board are criminal justice, a treatment center, and a shelter. So this next slide basically is sort of the meat of what we're talking about here, and that's our Narcan distribution. We distributed over 5,300 Narcan kits over the last year. The majority of those kits were in Penobscot County and mainly in the Bangor area. Only about 109 of them were distributed outside in Penobscot County, but outside of the Bangor area. Those were places like Dexter, Newport, Lincoln, Millinocket. We don't have very many T2s in those towns or in those areas, and the numbers really show it. So if you want to be a T2 in those areas, please reach out to us. We really need you. But the good thing is Maine Access Points does have some people around in those areas, and they can help fill some of those gaps. But I don't think they have people in all those areas. So we need more. But this covers the demographics for now. I'm going to move into like some of our successes, and some of the successes are that we did distribute 5,300 Narcan kits and trained 387 people, despite being in a pandemic. And really, during a time that I was just learning my job. And I think like the first quarter I was here, I maybe trained 3 people. And so I've really learned so much. I really appreciate being here. So it also reflects several weeks that we couldn't fill any of our Narcan requests because we had completely exhausted our Narcan budget. And so we were working with the state to get additional funding, which we did get. But during that time, of course, we weren't providing Narcan for any of our T2s, and I wasn't doing any outreach or any onboarding. So I think these numbers would be higher if we didn't have that gap in funding and the gap in service. So I think like there's many other sort of harder things to measure that I do consider successes. And one of those things is like the amazing work that's being done through our communities and coalition groups. I'm really proud that we're part of that. Those organizations, like organizations outside of the norm, who serve really vulnerable populations. And those are like libraries and transportation services. They're reaching out to us and wanting education and training. And they're doing it from a place of like compassion and care and interest and willingness to learn. And I think that's just from the work being done at the local level. And that's really encouraging to me. I feel, again, thankful for that. And so the last thing is unfortunately, there's still challenges. And some of the challenges that we have, and I think you'll probably hear this echoed throughout the rest of the presentations as well, is that our stigma, information, and resources. But so this slide has the distribution numbers, both of overdose deaths and Narcan distribution. So Bangor makes up of the last 6 months. So Bangor makes up about 17% of the state's overdose deaths, and Bangor is where most of the Narcan is going. But there's still plenty of service area gaps and access issues, even with MAPS overlap. There's still gaps that need to be covered. So even recognizing that those rural areas have a different infrastructure with fewer suitable places and suitable people to become distributors, we know that, but at the same time, like we want to save lives and we want people to have the same access to the life-saving medicine that Narcan is. So it's really hard and it's a balance, and it really, for us, it puts access at the top of the challenge list. along with stigma and information and resources. So people need information about access, right? Information about the importance of calling 911, about not using a loan, about safe storage, all of those things. But that information is not always out there because of stigma. So that stigma then impacts the access and information, and it becomes this like vicious cycle. And all of those things then impact those suitable organizations who are willing to distribute or not willing to distribute, because without education and information, they're fearful of distribution. And that leads me back to that liability question and that impact question, because the top questions I get are, what's the liability, and is this going to hurt someone? So I'm just hopeful that these efforts will continue to move this work forward and help people, because people are dying, and we really want to fill those gaps. So I'm not going to go over this slide, but if someone's interested in becoming a T2 and you're living in our 5-county area, please reach out, please. And that contact information is right there. So I hope to hear from you soon. I'm looking forward to hearing from you. So up next is Shane Gallagher from Maine General.
Thank you, Denise. Good morning, everybody. My name is Shane Gallagher. I am the program manager for harm reduction at Maine General Medical Center. So our programmatic outlook, when we entered this partnership with the other T1s and the University of Maine and the state of Maine, was that naloxone should be available widely everywhere, not just throughout our service area, but in the state. We felt that the effort should really be focused around reducing stigma, as has already been mentioned twice now, that there is just a lot of misinformation out there about who should have it, why they should have it, how to use it, what's going to happen. So we really felt that focusing our efforts around education to eliminate those myths was very important. And the last piece is that naloxone should be prescribed. It's a best practice when it's appropriate in clinical settings. And it should be a first option for a provider who is having a patient who they feel might benefit from either naloxone or Narcan prescription, but also to be mindful of that there are situations where the individual might not want a prescription because of perhaps their substance use is not well known. They don't want it being released through the insurance companies and possibly their employers. Next slide, please. So we cover about a third of the state, roughly, by population. It's closer to 38%, but we cover 9 of the 16 counties. We have 63 organizations currently in our distribution network, predominantly a lot of healthcare organizations, hospitals, FQHCs, private primary care practices, private behavioral health providers, treatment organizations, 8 of the 9 liaisons in our area for the options program we've been working with, as well as correctional facilities, law enforcement, some EMS and fire in there, and then other community agencies that, like Denise mentioned, are places that you wouldn't expect, but they serve very vulnerable populations that are high risk, like transportation. So within those numbers, I had 63 posted, but if you add them all up, and I know some of you are, it comes out to 61. And this is why. We have a syringe access program, which has 2 locations, and I took those 2 out when I did the individual type of organization calculation, but not the total. So that's why there's a difference. We have given out, since we started distributing in May to August, 2,135 naloxone kits just to exchange members or non-members, but they're members of the community who have actually somehow heard about the exchange and come in to just get Narcan. We distribute predominantly to folks in the Augusta and Waterville area, but anybody who walks through the door can receive our kits. We also receive additional overdose information from people who come in and get refills for their Narcan. Becoming a T2, if you're interested and you're in our service area, you can reach out to me. We require everybody to sign an MOU with Maine General just to get everything situated. And if you need a standing order, if you don't have medical personnel on staff, we'll happily provide you with a standing order. But if you do have advanced practitioners or doctors on staff, then it makes the most sense to have them do the standing order for your staff. Our trainings are very similar to Portland, Bangor's, and MAPS. We all cover basically the same topics. Anybody who joins with us through a T2 will learn a little bit about opioids, the risk factors of overdose, signs and symptoms of overdose, how to actually respond, and then the aftercare that Hillary mentioned earlier. We talk about the Good Samaritan Law, some general information, myth busting again around naloxone. And then for T2s, we get into some of the more logistical topics around data collection, how to store your supplies, and the reporting requirements. So lessons learned for us, since we have such a high volume of healthcare facilities, what we've seen is there's a lot of good intention, but generally an overestimate of how much Narcan they're actually going to give out for a variety of reasons. Not just the location, but it has a lot to do with culture within an organization, the culture of the geography they're in. And we have to do a lot of education around that with different organizations to give them a reasonable amount so that we can make sure that the naloxone we have is spread out as much as possible and will last as long as possible. And then the second thing we learned is that when we started giving out naloxone within our exchanges specifically, it really opened the door for having these really trust-based, open conversations around what people were seeing. We had some in the past, but once we really started delivering Narcan in the exchange itself, our membership just really opened up and told us a lot more about what was going on in the community, which has been very, very beneficial for future things. Now I'm going to turn it over to Bridget Rauscher from the City of Portland.
Thank you, Shane. Hi, everyone. My name is Bridget Rauscher. I am the program manager for the City of Portland Public Health Division's Chronic Disease Prevention Program, and I also serve as the city's local health officer. Thank you all so much to the participants for being here today and for your interest in learning about our program. And also, I'm so grateful for the chance to share this program alongside my colleagues throughout the state. And I'm really hopeful that after this seminar, I'll be hearing from some of you who are interested in obtaining naloxone from us. At Portland Public Health, our naloxone distribution objectives include ensuring widespread access to naloxone throughout York and Cumberland counties. We were lucky in some sense that prior to the initiative, we were able to obtain and distribute naloxone through our syringe service program, but that was really relatively limited to the clients who accessed our program, and some opportunities for community members who were in need. We also advocate for individuals with the means to do so, to access naloxone via the pharmacy. And this applies a lot to folks who maybe want to do the right thing and be a general bystander by having Narcan on hand. And it really assists in reserving the state supply for those who will truly need it. And it also normalizes the accessibility that Shane was talking about and reducing stigma associated with obtaining naloxone. And providing education and training opportunities for recognizing and responding to opioid overdoses. And if an agency is not enrolled as a tier 2 or T2 distributor with us, we still provide and make available education and training opportunities throughout Southern Maine, which is a necessary piece of the prevention model that we are committed to. And also to promote the Maine Naloxone Distribution Initiative and increase T2 engagement, which is hopefully going to happen as a result of this, but we're constantly onboarding new sites and we'll continue to do so. And so we're very lucky as a state as well to have the financial and programmatic support offered through MNDI. So our program serves York and Cumberland counties, which is perhaps the most urban distribution profile due to the coverage in Southern Maine. Obviously we are population dense down here. And since the project start, we've distributed naloxone to about 52, probably more than that, network members, including our public health partners, healthcare providers, community organizations, public safety entities, and options programs most recently. And we also, we function as a T1, but part of our program functions as a T2. As I mentioned, we operate the southernmost, well, prior to MAP, the southernmost syringe service program down in Portland. And in 2020, we served over 700 unique individuals. And in this current year have distributed over 3,000 doses to our clients through strictly our syringe service program. So to become a T2 with Portland Public Health, similar to what some of the other presenters have said, we require a signed naloxone distribution acknowledgement that agrees to following the state of Maine community naloxone distribution guidelines. The T2 agrees to conduct adequate and timely naloxone training to recipients of state supplied Narcan, utilizing some of the messaging that Portland has adopted. And not just because it's Portland specific, but because we do believe in consistent training and consistent messaging across the state. And we expect the T2 will collect and report de-identified data for distribution as well as overdose reversals that are reported. And also that you'll collaborate with us for technical assistance needs, because that is what we are here for. In terms of establishing a standing order, and I've seen this a little bit in the Q&A and the chat, an agency can provide their own. We do always ask an agency if they have a standing order, but we also have a standing order with our medical director that allows, you know, in the spirit of community-based distribution, it allows non-medical providers and non-healthcare centers and agencies to obtain naloxone under our standing order. So not having access to a standing order does not preclude you from becoming a tier 2. We also require the tier 2 to provide us with a distribution protocol for the agency. And we really feel as though the distribution protocol really assists in creating a uniform response to something that a lot of times can feel chaotic. And having a protocol in place can really help to alleviate anxiety and stress during an emergency. And also we want to make sure it's, you know, naloxone is being stored properly. And the training requirements, as others have said, very similar. So T2 staff should be trained in, you know, an introduction to opioids, especially for agencies that maybe have less experience and familiarity, recognizing signs of an opioid-related overdose, then some basic, you know, information about what Narcan or naloxone is and how it works, including the efficacy and duration, proper administration, and then working with around monitoring a person post-administration while waiting for law enforcement, the Good Samaritan law, and other community support services, and ordering in proper storage of naloxone, because that is important. And so I hope to hear from some of you. Please contact us, reach out. We're happy to provide more information or get the process moving of enrolling you as a tier 2. Thank you.
Thanks, Bridget. At this time, we'd like to return to me from the Maine team to discuss some of our 30,000-foot insights on cultural hurdles and challenges and barriers more broadly to naloxone distribution in Maine that we've learned a lot more about during the duration of this project. As our T1 panelists have noted, the primary challenge that persists despite the success thus far, we think, the MNDI, is stigma. And despite progressive change in both our legislative efforts and our general public culture across the state in trying to address the opioid epidemic, we have found that stigma persists as a mitigating factor in complicating connection to services and outreach to at-need populations. Stigma is an issue both amongst the general public and even in the professional circles, which are parallel to and providing care to individuals suffering from substance use disorder and experiencing overdose, principally amongst the law enforcement population, clinical practitioners, and pharmacy staff. This isn't necessarily an indictment of any of those populations, obviously. It's a note, though, that complicating factors about cultural views on substance use disorder, overdose, and people who suffer from substance use disorder and overdose complicates the connection to services and the care that these folks receive. Part of recognizing this is understanding that end users of naloxone, recipients of this life-saving medication, people suffering overdose, and people suffering in the throes of substance use disorders rarely experience these challenges in isolation. Substance use exists co-occurrently with other socioeconomic marginalities, particularly poverty, transience, rurality, lack of mobility, people experiencing racial inequity, people suffering from lack of connection to care and services like childcare, connections to goods, people suffering from mental health crises, physical disability, or chronic illness, and particularly in a state like Maine, where all these compound difficulties acquiring transportation and basic pathways to care and connections to services to otherwise mitigate factors compounding overdose. Some logistical hurdles have also been seen over the course of the project. In the past, this is improving in the present, but has been an issue historically, and the T1s can probably speak more to this. Legislative and law enforcement inconsistencies over time have caused a culture of confusion around what liability is, as the T1s have discussed, and uneven application of community distribution rules and Good Samaritan laws has not helped in the past in clearing any of this up. This means that even as the legislation improves the state of harm reduction in the state, especially on the end user side, there's hesitancy and confusion. And this can make it more difficult for people who are interested in getting involved with harm reduction or who require it and getting the care they need. Also, as the T1s have noted, a lack of proper education around basic facts pertaining to naloxone causes widespread misunderstanding of basic administrative and clinical concepts pertaining to naloxone, which can be as simple as issues with understanding the nature of the proper storage of the medication and proper administration. In Maine, where we experience drastic climatic changes in various times of the year, for example, folks who are operating as remote bystanders, perhaps leaving naloxone in things such as a vehicle, may not be aware that temperature changes over the course of the year can render their kits inert, effectively then putting the person who they may be interceding upon experiencing an overdose at an increased risk of not getting the care they need. The same goes for improper use of the drug or improper administration, and these gaps in education can lead to naloxone waste or misuse, costing resources and potentially lives. That being said, we've learned a lot about success stories and lessons. One of the key successes that we've taken from the project thus far is that the role of active bystanders cannot be overstated. They are key to overdose reversal in Maine and beyond. A person suffering overdose can't intercede upon their own overdose necessarily. So people suffering overdose are reliant upon the intersection of active bystanders to save their lives. These can include family members, friends, use partners, other forms of loved ones or acquaintances, and Good Samaritans. Therefore, the saturation of communities throughout Maine in have it on hand naloxone supply can provide a potentially life-saving safety net. Alongside this, making sure that that proper training for naloxone storage and use is received is critical to ensuring that supply is then operationalized to save lives as best as it possibly can. Some other important things that we've learned, particularly on the research and assessment end at the UMaine team and working in coalition with the Naloxone Steering Committee, our public health partners and our T1 panelists here, is that it's very important to gather data about the recipients of these services, either naloxone or the client populations, both the T1s, the T2s, and the needle exchanges throughout the state. Because the more we understand about people suffering from substance use disorder in Maine and people suffering from overdose, the more we can tailor interventions to best meet their needs. Answering some common questions like, what is the housing status of people suffering overdose? Do they suffer from multiple overdose events? Is this a chronic problem? Do they have safety plans in place? Are they ready to engage in treatment and recovery processes? And if so, are the pathways there to provide them with access to those things they need? Is something stopping them from doing so? Either a disconnection of care or services, a legislative barrier, or other socioeconomic mitigating factors? And are they using alone? Because that can be a big factor in whether or not an overdose event is fatal or reversed. This brings me now to the final portion of the presentation where we want to discuss some up and coming resources. As of today, getmainenaloxone.org going forward will serve as the digital hub online for the Maine Naloxone Distribution Initiative. We view this hub as serving as a locating nexus for information on naloxone in Maine, both in the MNDI context and outside of it, as the T1s have discussed. This will provide access to those links needed to onboard as a T2, to get information about acquiring Maine Naloxone Distribution Initiative naloxone supplied through SSPs, information on 211 and referrals to Maine access points, and coming down the line later on, information about public-facing T2s in the MNDI network with open distribution access. We also want to pertain information here that is relevant to pharmacy access, because as the T1s have stated, that is a critical pathway to naloxone if it's viable for the end user in question, and then have more information about general naloxone availability statewide. Some of the content you've seen here in today's presentation explaining the schema breakdown of the MNDI more broadly, its context and its goals will also be available there, as will expanded direct documentary access to the legal information regarding the Good Samaritan Law, the executive orders, information on the Attorney General's distribution programs, distribution to jail and corrections, as well as the Good Samaritan Law, the Naloxone Distribution Law. We'd also like this to serve as a hub for educational multimedia materials about naloxone and overdose response, including educational materials targeted toward destigmatization and normalization of naloxone administration and use. Principally, we'd like to advertise the ODME mobile app and its resources, and I'll get to that in a moment, as well as any other multimedia educational materials collected from the public domain and the T1 and T2 networks throughout our state. We will also be posting metric snapshots of success stories emergent from the MNDI on this website, containing infographics and counters for things such as some of the statistics you've seen here today: distribution numbers, reversals, non-fatal overdose events, and mapping and GIS analysis of said data. This is also a sister website in many ways to the primary one-stop shop for all drug-related data in Maine, mainedrugdatahub.org, and you can find links to that website there as well. Here we just have an information slide available advertising the ODME mobile app, which was produced via partnerships between the Office of Behavioral Health and the University of Maine with input from our T1 stakeholders. And this is intended to be a low barrier to entry, easy to use educational tool for folks responding to an overdose with either intranasal or intramuscular naloxone. It contains audio and visual cues and instruction for administering the life-saving drug, has information on signs of overdose, information about opioids themselves, and links to the Good Samaritan Law 211 and public health resources. There's also a voluntary overdose reporting tool included in the app. The app can be found for free on both the Google Play Store and the Apple App Store. With that, I'd like to hand the floor back over to our panel and open the forum for questions and discussion. Thank you all for being here today. And I see a question in the chat about slides being sent out to participants, and I believe the answer is yes, they have been converted into a handout format.
They were emailed just before the webinar began, about an hour before, and I just put them into the chat as well. Do we want to start answering some of the questions in the Q&A? There's plenty.
Sure. Do any of our T1s want to start taking a stab at the questions? Or would you like, I see we have a question most recently regarding, are there sample safety plans in place? Do we have a sample safety plan across the MNDI?
I would say that safety plans are really specific to the organization and environment that you're working in. And so while we have some general kind of guidelines, I think it's most meaningful to work with one of the T1s to really create a safety plan that makes sense for your space.
I see another question here about the difference between a tier 1 and a tier 2 organization or distributor. As we discussed earlier in the presentation, the primary difference is that the tier 1s are the recipients of the state funded naloxone, and then they distribute to their subsidiary networks of tier 2s. And within the tier 2 category, you have different kinds of tier 2s, either tier 2s who serve as community redistributors themselves, who are the main vehicle of the naloxone reaching the communities throughout the state, or have it on handers who are organizations or individuals requesting a more acute supply for preventative active bystander use internally.
I saw a question about recovery centers and recovery coaches, and certainly all of the tier 1 programs or T1 distributors do work with recovery centers in their catchment area, or with MAP, we'll work with you anywhere. So definitely reach out. There was also a question about, can you give naloxone to a dog? So if an animal got access to an unsafe supply, you can absolutely provide your animal with naloxone.
For the most recent question in the Q&A, as a primary care office, would we be a tier 2? The answer is yes, you could enroll as a tier 2 with your local tier 1 or your assigned tier 1.
I see the question about the stigma as the barrier, and I just wanted to, I'm not sure what evidence-based programs are being used, but I do know that there's lots of campaigns. Like originally there was the Have It on Hand campaign, and now I know the Options campaign is out there, and you may have seen some of the commercials on TV about people in recovery and their stories. And if you go to knowyouroptions.me, you can find lots of information about the Options program and some of the information about where you can get naloxone and where you can find treatment, and things that are specific to your area. There's a lot of resources there right now, so that's one that I'm aware of.
Okay, I see, hello. I see your question in there regarding what OBH is doing to support RNs in dispensing naloxone. And I think that is a question that we can commit to getting back to you on. I know that in these forums, all questions are answered, but there isn't a representative of, well, maybe there, I'm not sure. Josh, could you answer that question?
I can't answer it at this time. No, I'm newer to the role. So I just want to make sure that I give correct information. But yes, as Hillary has addressed, we will get back to all of these questions. We just want to make sure that we give accurate information.
I see a question from someone in the audience saying that their organization is present in each county. Therefore, they'd like to know who they would reach out to specifically to become a tier 2. And I think that would really depend, and the T1s can let me know. I mean, I think it depends if your organization is spread across the state. Is there a difference in the service saturation at different sites? Which site would be your primary recipient of naloxone inventory? In that case, it would probably make the most sense to contact the organization T1 that services the area where you are going to require the most naloxone. Otherwise, I think Maine Access Points is also adaptive and able to assist throughout the state. So it would really depend. I would encourage you to get in touch with any of the T1s based on that feedback.
I saw a question in the chat about individuals being able to be distributors, and you can certainly reach out to MAP, and we can either support you in that process or get you connected to another T1.
I see a question about training, Hillary. I don't know if you'd like to address. This says, I became a Narcan certified at my job, and I am always having people ask me how they can be trained. Do you have to be licensed to train someone on how to use Narcan? And if so, can an individual not in healthcare do that?
Sure, yeah. You don't have to be licensed in anything, but we do provide folks with train the trainers. That's within the community distribution laws, that we train people to train others. So I think that would be an opportunity for you to reach out to one of us to train someone as a distributor. I think that we also all have information and can share it. And if you feel like you can help someone understand to use the naloxone that they have, you should support them in that. Harm reduction has, a deep history and knowledge sharing. And so none of us own this information. Certainly, if you're going to be distributing naloxone, you want to get set up as a tier 2, but we should always be sharing information with each other and then linking people to the resources that can support them.
Josh, I don't know if the state's able to speak to the question I'm seeing in the chat regarding the expansion of DOC supplied naloxone to all persons leaving jails or prisons. That may be one of those questions we need to pass up the chain of command to get further feedback on. What do you think?
Yeah, absolutely. Again, just giving accurate information on that is very pertinent, but that's a great question. Thank you for bringing that up.
There was a second part to that question from Doug around the jails. So I can speak to that a little bit, at least for our catchment area. The jails are a little bit more difficult of a nut to crack because they have all of the same kind of cultural complications we have with other law enforcement agencies because they're run by the sheriffs. But then you add in the culture of each individual county or town that they're in. So it's really on a case-by-case basis. I know in our catchment area, we've been working with several of the jails to change that culture, to move towards at least getting Narcan for folks who were in some sort of treatment program, and certainly expanding to anybody who has a substance use on their record. I can't speak for the other T1s, but in our catchment area, we are trying to work with the jails.
I think that it's also really meaningful to connect folks who are experiencing incarceration just to peers and community. We have quite a few folks at Maine State Prison that have access to texting that reach out to the MAP phone. We text with them, we provide support, and then we're certainly going to make sure they have naloxone and other, supports that they need when they leave, whether that's safe use supplies, as our syringe access program, connection to recovery centers, recovery coaches. I think that some of that informal and formal peer support is another way to get people connected. And certainly you can pass our number along to folks who you may be working with.
And I see there's a good conversation happening in the chat about options working in tandem with correctional releases to try and connect folks to services as well. I think that's an example of increased efforts to pair people with the help they need. Although we will get back to all the questions on the expansion of existing policies as they stand. I see a question in the chat about school systems, stating that education and training is important in the school context, if not for students, then at the least for teachers. Do the T1s have insights on that?
I would add that the Maine Department of Education is actually registered as a T2 with us in Portland. And it, again, sort of depends on the district. We have several school districts with nurses who have Narcan on site. I don't think at this point that there's sort of secondary distribution to students or anything like that. But they do have the option, and we are kind of constantly evolving which districts are enrolled and are looking for training opportunities. We also separately offer, just our overdose recognition response education to the student bodies throughout our service area. And I think that probably also varies among T1s, but for Portland and for the Department of Education, that's what we have.
I just want to note really quickly, there's some conversation about expired naloxone in the chat happening, and I want to be really clear that expired naloxone is still effective in responding to an overdose. So if you have expired naloxone and that's the only Narcan you have, you want to go ahead and use it. It's not going to cause harm. And there are some really good studies out there that shows that naloxone is good for like 30 years after its expiration date. And let's remember, there was a long time in Maine when all we had access to was expired naloxone. So you should always go ahead and use it. Same if it is overheated or thawed from being frozen. We want to always use the naloxone that we have. And so often it is successful. We just may need to use a little bit more.
Do you have any more questions? Are there any other thoughts from the T1s that you'd like to leave with our audience?
All right. Thank you all for attending this seminar. It's been great. I just want to note once again that the next series will be Friday, October 1st, which is right around the corner at the same time frame. Hope to see you there. And great job, everyone presenting. They provided great information. They are the experts on this, so thank you so much.
Thank you, Josh.